to give you all an insight into how a volunteer can be an essential part in delivering an effective and useful palliative care service. And before we go into introducing our faculty, I would also say I can speak in Telugu. మీరు అందరికీ వందనము. మీకు ఎవరికి ఏమి డౌట్స్ అడగాలంటే తెలుగులో కూడా అడగొచ్చు. నేను సెషన్ తర్వాత మీకు ఏమి డౌట్స్ ఉందో అది నేను నాకు తెలిసే వరకు చెప్తాను. So with that, we can a warm welcome once again. Hope this session is useful for all of you. So that one, it will develop the interest, because basically all of you have interest. That's why you've decided to do this course. Next, these sessions will make you more aware what and how can you be part of a palliative care service. Okay, with that, we'll go ahead, Sinya, with the introduction of faculty and move forward with the session. Good evening and a warm welcome to Dr. N.S. Raju, who is a geriatrician and a palliative care physician too. And he's also a managing trustee for the Aged Care Foundation, which is a registered charitable trust at Visakhapatnam. And he is a member of the National Institute of Social Defense under the Ministry of Social Justice and Empowerment. And he is a vice president of the Dementia India Alliance panel. And he has an extensive years of experience in palliative care service. Warm welcome, and the floor is open to you, sir, to take us through the session.
Good evening. Thank you very much, Dr. Radha. Am I audible?
Yes.
Yeah. Thank you, Sinia. So, are you going to empower me to share the screen?
Yes, sir. You can share the screen. Sir, if you are having any difficulties sharing the screen, we can do it from our end.
Can you share the screen?
Yes, we'll do that.
I have an extended screen. I want you to.
Is it clear to you?
Are you able to see now?
Yes, sir.
Did you get the presentation?
Yes, sir. Actually, we are presenting it from our end.
From your end, is it?
Yes.
Okay.
We are able to see the presentation. Are you happy with this?
Okay. Yeah, fine. Okay, yeah. So good evening, everybody. Good to have all of you here.
Good evening, sir. Good evening, sir.
So we'll start with this is a very celebrated anthropologist, Miss Margaret Mead. One of her students asked her, what is the earliest sign of civilization? The students expected one of these answers: a clay pot, a grinding stone, or a weapon. And this is what she has answered. Her answer is a healed femur, which is about 15,000 years old. So what has it got with civilization? As you know, the femur is the longest bone in the body. It connects your hip to the knee joint. And it needs somebody breaks his hip, the femur bone, it needs about 6 weeks for it to heal. So for the bone to heal, somebody needs to take care of that person, protect him, feed him, and take care of him. Otherwise, there's never a possibility for the wound to heal. So she said, this is the earliest sign of civilization of one human being taking a good care of other human being. It's a very important, very interesting painting. It hangs in the Tate Museum of London. As you can see, the central theme of this painting is a sick child. But surprisingly, the title of the painting is The Doctor. So this painting was done by Sir Luke Flights in the year 1887. So why do you think it is called The Doctor? Why not a sick child? So I want all of you to focus on the painting and let me know in one word. You have to sum up this painting in one word. I'll give you a few more insights into the painting. It's a Victorian general practitioner making a home care visit. Obviously, baby is very sick. And if you can see in the background, the distraught father is there with grief written all over his face. And if you can see, his wife is there next to him. She had her head on the table, obviously tearful, very much distressed. If you just look at the background, it's a poor, maybe a laborer, somebody with a very poor economic background. You look at a couple of chairs which look dissimilar. They're brought together to make a makeshift bed. And interestingly, there's a cup of tea on the table. And you can see a lamp with lantern on the table. And actually, the sunlight is just beginning to peep into the room. So it's dawn, sunrise. That tells us the doctor was there all through the night. And look at his gaze. The focus is on the baby. So that's it from my side. So anyone can unmute themselves and make a comment, or else you can put it in the chat box. Just one comment on what you feel, what it makes you think about the whole setting. And mind you, that is year 1887. No antibiotics in those days, no imaging, none of the high-tech gadgets, not many surgical procedures. And what the doctor could have done in those days, spending the full night on the patient's side.
Observe the patient.
Yes, very good. Who is that?
Meena, sir.
Meena. Excellent. I like that. Anything else?
Sir, here, doctor is waiting with
Wait.
hope. What the response is?
Okay.
Another one is commitment by the doctor.
Commitment. Who is that?
Chakradhar.
Chakradhar, hello.
Oh, hi, Dr. Raju.
Good to see you here.
Thank you.
Okay.
The
Yeah.
doctor is a well-to-do person. He is wearing a suit.
Yeah,
And-
looks very elegant. Yeah.
And he can have a comfortable sleep at his own house.
Yeah.
He is sacrificing his comfortable sleep
Yes.
home and seriously observing the patient.
Yeah, agree with you. Yes.
What
Anybody
strikes
else?
me the most is the dignity that all three people have been assigned by the painter of this picture.
Yeah.
Whether it is the doctor, whether it is the patient in bed or the patient's father,
Yeah.
there is a lot of dignity that has been attributed to each and every one of them.
Yeah, wonderful. Thank you very much for that. Yeah, I agree with you. So, anybody else?
But Raju, one observation is if it is in our place, we keep our baby in our hand or in our lap.
Yeah.
So or we don't know what is the sickness, but most of the cases that's what we do in our Indian
Yes.
settings.
In our culture, yes, right.
Yes.
So obviously the child is very sick, and it looks like it has been the whole night, right? So maybe even the parents are very much tired. Okay, so wonderful.
The doctor is still expecting or really thinking of what can I do further to really help this child and the family.
Yeah, what do you think? See, in those days, in the year 18,087, when none of the knowledge that we take for granted now was available in those days, what he could have been done, what he could be doing, what is that is expected of him, and what are the tools, what is the what are the insights available to him? He doesn't have the luxury of an ultrasound or X-ray or investigations, nothing of that sort, and hardly any medicines. It actually conveys a very important point for us in palliative care. Okay.
Rightly trying to see the signs and symptoms evolving.
Yeah. Yes.
So the observation as rightly
Is
said.
intently observing the patient as somebody has observed.
Yes.
So the central figure is the imposing male doctor gazing intently at his patient, while in the background the father looks on helplessly, has his hand on the shoulders of his tearful wife. So if you want to sum up the essence of the painting, I will say it is the presence. I will repeat that word. It is the presence. It was the intensity of the doctor's gaze and his posture. It was his presence. We can always say the doctor was all in, right? He had his 100% there in the room for the patient. So what is presence? So when I read more about this painting, this is what they have written in this that review. Presence is the mindfulness that one individual brings to an encounter with another. It is a defining element of human connection. It is a focus of mind, spirit, and intent around a moment in time that is about another person and his or her most pressing problem. So presence, be it in a clinical examination room or with a friend over a cup of coffee, is a uniquely human gift. So going back to the 19th century, the effectiveness of the medicine or the doctor's contribution was unlikely to have had any influence on the recovery of this patient. But yet, it is a very respectful painting of a physician, because the physician is doing something really important, that is being there with the patient and his family at the time of their need. What do you see? Any comments on that? I invite comments on that. Is it important? Even when nothing can be done medically,
Yes, sir.
the presence of a doctor, it need not be a doctor. Although I've been talking about the doctor, doesn't mean that it has to be a doctor. It can be a nurse.
Presence of a compassionate.
Yeah, it can be a relative, it can be a friend, it can be a well-wisher, it can be anybody, it can be a volunteer.
Yes.
Yeah, go on, please. Yes.
And also give moral support, is it?
Yeah, it is moral support, and it is actually it's very important. See, you never realize the importance of just being there. Many times we expect that when we are there, something is expected from us. It is possible sometimes, and when it is possible, and when it is, important, when it is helpful, yes, just being there may not solve many problems. But even when there is nothing else to do, still our presence matters. That's the point. See, when we are there, there'll be a lot of things, particularly in that present scenario. There'll be a lot doctors, nurses, volunteers, or another allied health workers will be able to contribute. But even when all that is not appropriate at a particular context or a particular moment, still your presence is very, very, very important. It need, again, I would like to stress that it need not be a doctor, it can be anybody else. And it is easy in our technological age, when there is so much that we can do for the patients, to forget how important it is to be with the patient. So the relationship with the doctor and the patient is actually very important for healing. That's what this painting is all about. So thank you for that. So we'll move forward now. So what is palliative care? Let me start talking to you by giving the most important take-home point of the day, the definition of palliative care. So before speaking to you about what palliative care is, I want all of you to carry this message, if not anything else today. What palliative care is not. So palliative care is not end of life care. Many of us, when somebody says palliative care, what comes to our mind is end of life care, good death, how people die, the process of dying. But please take home this message and spread it around, that palliative care is much more than end of life care. So today evening, I have some wonderfully good news to you, all of you, and followed by some bad news also. So I think good news should always come first. So the good news is that there has never been a better time to be alive if what you want is to be alive. If you look at last 30,000 years of known human history, the life expectancy was always hovering around 28 or 30 for 30,000 long years, although it has been shown for 10,000 years. For 30,000 long years, the human life expectancy, irrespective of what our grandfathers told us, the average life expectancy was hovering around 28 to 30. And then it all started in the present century. It just went up and up and up. Can anybody make a guess what is the most important single contributing factor for the increased life expectancy? Anybody? Make a guess. What made this possible? For what remained stagnant for 30,000 years, suddenly from 30 it went up to 75 and 80 in some of the Western nations.
Medicines? Medical help.
Vaccination?
Vaccination, yes, medicines. And thanks for, madam, you said medicines. It's undeserved credit, but thanks for saying that.
Antibiotics.
Antibiotics, yes. Made a note. Antibiotics, yes. Vaccination, yes. They played a big part, but not the lion's share of what was responsible for this increased lifespan. The biggest contributing factor, surprisingly, And discouragingly for doctors, it is public health engineering. Safe drinking water, separation of sewer line from water line, safe food, availability of nutritious food. They are mainly responsible for this quantum jump in the life expectancy by avoiding most of the waterborne and foodborne infections. Of course, antibiotics and vaccination played a big part next to what I said. But then in recent times, modern medicine played a part, but it is still a small part only. Yes. So what is the bad news now? The bad news is that the world mortality rate, unfortunately, remained steady at 100%. And do you have any plans to change that? Unfortunately, no. For all times that we can see, there will not be much change. There will be still, death rate will be 1:1. World Health Organization expressed disappointment on Monday at the group's finding that despite the enormous efforts of doctors, rescue workers, and medical professionals worldwide, the global death rate remains constant at 100%. How do you like that news? So what is the challenge here? We're leading to some other important issue now. The challenge is that we have not only this is the challenge not only just for medicine, it is challenge for the human species. It is that life is long, life is wonderful, but life is finite, life is limited. This is the reality that we all live with. This is both a challenge and also a gift. It tells us that we need to do our best with the time that we have and to spend it the way we want and with the people that we want. So this is a challenge that we need to address. So welcome to palliative care. So now again, back to all of you. I'm sure some of you might have searched for palliative care. Maybe some of you are already familiar. Maybe some of you are from a healthcare background. Might have had some family member or friend who got benefited by palliative care. So I want your first opinion about what you think palliative care is. Open. Anybody?
There are some responses in the chat box. You can see, or do you want us to read and say, sir?
Yeah, can you please read it for me?
Yes, I will read it to you. For what are their opinion on palliative care? They've said increased quality of life, improved quality of life of the patient and family members. First, better quality of life, live with dignity, providing good quality care, provide moral support with minimal painkillers, providing unconditional emotional support.
Okay.
Combined effort of, very nice one, combined effort of doctors, family, caregivers, etc.
Okay. Okay. It's a multidisciplinary team approach. Okay. Who
Support
said that?
physical and mental, give mental and physical support.
Okay.
Good variety, relief of pain.
Relief of pain. Is it
unconditional support.
unconditional support? So anybody knows where this word came from? Palliative. It comes from the word pallium. Does anybody have an idea about this? Pallium, what does that mean? Pallium is something like a garment. It's actually called a cloak, C-L-O-A-K. It's like a coat, a jacket, which you cover your body with without sleeves, without hands, sleeveless. So what the wording, why the title has been given for this care is, even when the disease or the sickness is not curable or treatable, still we can give a protective coat over the patient and also the family to insulate him or to comfort him from the ravages of the illness. That is, to reduce the suffering, to make him as comfortable as possible and as long as possible. Somebody said quality of life. I'm only saying that in different words. It's well said. So palliative care is all about living as well as possible and as long as possible. I'm not going for the definition given by the World Health Organization, which we'll be seeing after some time. Let's keep it simple right now. So the ultimate goal of medicine, healthcare, as you all know, is to cure the disease. It is everybody's wish. It is the wish of the family, it's the wish of the patient, and the wish of the treating doctor also, to cure the disease, to make him completely normal, to eradicate the disease. That remains the single most desirable objective of healthcare. But when we are talking about that longevity, our life expectancy went something from 30 years to now about 75 to 80 or even more, depending upon where you are living. Does it come without a cost? No. It comes with a cost. The cost is that we are now learning to live with sickness. More to it after a few minutes. So this is Dame Cicely Saunders. People affectionately call her as the founder of the modern hospice movement. Very interesting story. She started her career as a healthcare provider, being a nurse in Great Britain. Her husband was a Polish gentleman. He was suffering with cancer. He suffered and died in the hospital where she was working. And she was very, very distressed about the suffering he went through. And the way the medical and nursing fraternity, the healthcare fraternity, treated him or could not treat him for the suffering that he underwent. It's more about the inadequate pain management. She was so disturbed, she left the job. She went on to become a social worker, tried to influence things to provide more pain relief for patients suffering with mostly cancer, advanced cancer. And she came to know that it's very difficult to convince doctors unless you are one among them. So very interestingly, she went back to the medical school, became a physician, established the first modern hospice in London. It's called St. Christopher. Still there in the suburbs of London. She practiced, she trained and inspired hundreds and thousands of palliative care physicians and nurses all over the world. Was instrumental in spreading the palliative care movement. And at the end, she passed away in the same hospice which she helped establish. Very inspiring story. Dame Cicely Saunders. So this is, there are many definitions given for palliative care. They all help us in looking at palliative care from a different angle. Some of you have defined it very well. So look at this definition. It's care focused on improving the quality of life for people with serious illness. This definition has been given by Center to Advanced Palliative Care. The original definition, which has been given by World Health Organization, was 20 years old. We'll have a look at it in the coming slides. That looks like a bit outdated now, because we learned so much in the last 20 years. Now, the time has come to change it, and World Health Organization will be doing it. But meanwhile, look at this definition also. It is more broad-based, because when you say it's a palliative care is for life-limiting illness, palliative care is for incurable illness, palliative care is for end of life, then you're limiting the scope of palliative care to a small group of patients, and thereby you're making it unavailable to many other people who actually need it. So the need for palliative care should not be based on the diagnosis. It should not be based on the age of the patient. It should not be based on the academic or social status of the patient. It's not for the abandoned people. It's not for old people. It's not for people who cannot pay for the treatment. But it includes all of them. So none of them are the defining criteria for somebody to be eligible for palliative care. But this is a very important thought. Look at it. Irrespective of the diagnosis, irrespective of the prognosis, how long the patient is likely to survive, if palliative care is available for all those people who have serious suffering, which is health-related, serious suffering or serious health-related suffering, I think this is much more broad-based than what we are looking at in the other definitions. So Lancet is a very reputed healthcare resource magazine. In its report in 2018, it said worldwide, more than 25.5 million people. Okay, that's almost half of all the deaths that happened in 2015. That includes 2.5 million deaths in children. They all had serious physical and psychological suffering as a result of the disease, injury, or illness. I'll say it once again. We are talking about the people who have died in the year 2015. The people, out of the people who died in 2015, almost half of them, that's about 25 million people, had serious physical and psychological suffering before they passed away. Add to this, over and above this 25.5 million, at least 35.5 million people who did not die also experienced serious health-related suffering in the year 2015. So that takes the total to 61 million people in the year 2015, including those who have passed away and who survived the sickness, 61 billion people, and which includes 5.3 million children. So the burden is associated with most of the non-communicable diseases like cancer, cerebrovascular disease, lung disease, and don't forget dementia. September being World Alzheimer's Month, let's not forget people who cannot remember, people with cognitive decline, people with Alzheimer's and other dementias. 21st of September, we observe the day as World Dementia Day to create awareness and mobilize support for the people with dementia. That is observed all over the world. And here I would like to highlight that palliative care mostly is synonymous with cancer care. Somehow palliative care started with treating cancer patients. Till this day, if you look at other ailments, it is the cancer patients who are actually availing maximum amount of palliative care services anywhere in the world. The other people, the suffering is not less in many other diseases. Don't be under the impression that cancer causes more suffering compared to other diseases. Diseases like renal failure, diseases like interstitial lung disease, respiratory diseases, dementia, the suffering is not less than what is experienced in cancer. It has been reported in many studies that in cancer, the disease trajectory is generally short, generally predictable. We know what is going to happen most of the times, and it happens within a short frame of time. And most of the time, the people will be functional to very, very large extent till the last stages of the disease, and suddenly they deteriorate and die. It doesn't happen in chronic non-communicable diseases like Parkinson's, like dementia. People survive for anywhere between 5, 6, 8, 10 years. There's a gradual decline of their function. Tremendous amount of symptom burden. And the stress and strain on the family is much more comparable to what is experienced by families belonging to patients with cancer. So palliative care is as important in non-oncological diseases, but most of the hospices and most of the palliative care, even today across the world, is mostly directed towards cancer patients. This has to change. So let me express my gratitude to my teacher and mentor, Dr. M.R. Rajgopal. We are now running a palliative care organization in Visakhapatnam for the last 11 years now. I've been trained in Pallium, India in the year 2012. So whatever we did so far in the last 11 years, whatever journey we traveled, whatever I learned is because of that one single person, Dr. M.R. Rajgopal. And much of today's presentation is actually inspired by his presentation. One of the wonderful communicators and most inspiring persons I have ever seen. It's not for any other reason that he's called as father of palliative medicine in India. So these key messages are from his presentation, which Shri has kindly shared. So the number one is palliative care is for serious health-related suffering. And as somebody has said very well, suffering happens in many domains. It can be physical, mental, social, and spiritual. Most of the times, all will be there in differing proportions in each patient. And also remember that Each of these domains causes some pain in the other three domains. They're all interdependent. The third is very, very important for all of us. Palliative care is everyone's business. By now, I'm sure many of you will be thinking about something that happened in your family, in your extended family, in your friends. We keep telling our volunteers every time that whatever we are doing in this palliative care, we're not doing any charity or any service to the society. This is something we are building for ourselves. What we are doing today, training somebody, teaching somebody, creating awareness, training a nurse, starting a palliative care center, supporting a palliative care center, it's all we are doing with enlightened self-interest. Because none of us can say that we will never need this. Or my father will never need it. My mother never needs this. It is something which can touch any one of our lives. It need not be you and me. It can be, yes, but it can be somebody's mother, my mother, your sibling, your aunt, your uncle, your friend, your neighbor. So it's very important for all of us. We are all in it. Each and every one of us are in it. If we are doing something to improve these services, to improve the accessibility, improve the quality of palliative care services, to make it available in more institutions, make more doctors aware, make more nurses aware, it is for our interest that we are doing it. We're not, let's forget about the community and all that. We are part of it. So the fourth point is, ideally speaking, these services should reach people everywhere, all corners, all settings. These services should be available at home. These services should be available in OPD. These services should be available in any hospital that you may go. These services should be available in the emergency room. These services should be available in ICU. And these services should be available in hospice. For those who need it. I'm not saying that every patient in every setting needs palliative care. It's not at all. But if there is a need, the service should be available at any place where we go for accessing any healthcare service. Long back, I remember. Anyway, before going further, it's good to know that the access to palliative care in India is a dismal 1.5%. Studies differ. It's about 1.5%. The access, leave alone that state of Kerala, where the access is better than many other developed nations. Maybe it's about 55%. Dr. Radha, is it 55% or more now? So Kerala is something we all look up to.
Yes.
Dr. Radha, what is the access of palliative care now? Is it above 55% now?
See, in Kerala, what it is available only in Kerala. It is not.
Yeah. I'm talking
by
about
number, exact figure, whether it is 50-55%, I am not sure.
Okay.
But what I have worked in Tamil Nadu for 3 years.
Yeah.
If you compare, what is available in Kerala is not available.
Yeah, I understand.
Even in Tamil Nadu.
Yeah, absolutely. Yes. No other state. There's no other state which can, claim anything near to what Kerala has done it. As far as I know, each and every primary healthcare center in Kerala has at least one trained palliative care nurse.
Even government setups have got a palliative care department at least.
Yes.
I've seen in like primary health centers.
Yeah.
They have an outpatient.
Yeah, I know. So just look at it. We have a 100-year-old government hospital in Visakhapatnam. It's called King George Hospital. Just about to complete 100 years of its existence. 100 years. One of the foremost wonderful medical teaching institution. Unfortunately, we don't have a palliative care unit even today. And long back, I remember one one lady from a tribal area was brought to our hospice, 8 years, 9 years old. I mean, sorry, 8 to 9 years ago. We gave her morphine and asked her husband to bring her back for review after 30 days. He never came. After about 45 days, he came back, brought a few oranges for us. And we were very angry with him because we know that she would have exhausted our 30-day supply of morphine. And he came now without bringing his wife along. When we were rather angry with him that he did not bring his wife, he put a very sad face and with tears in his eyes, he said, "Sir, I had to carry my wife for 3 kilometers on my shoulder to reach the nearest motorable road." So such places exist, unfortunately, even today. So the idea is, the aim and ideal is to reach people where they are when they need care. Dr. Rajgopal talks about a declaration called Astana Declaration, which is from year 2018. There was a call. It is a call for all countries around the world. They agreed to the declaration of Astana, owing to strengthen their primary healthcare system as an essential step towards achieving universal health coverage. They also said, instead of health for all, we have health for some. So we have solemn responsibility to ensure that today's declaration on primary health center enables every person everywhere to exercise their fundamental right to health. Did it happen? We all know where we stand today. So very important point is the last one. Everyone has to be accountable and follow core values. So now most of you joined this course because of maybe you have to tell me why you joined this course. Maybe there is an inner call, there is an innate goodness. Of course, you will tell me now what made you to join this course. I know that this will not give you any monetary benefit. It will not improve your status. It will not buy you a new car or a new house. It will not take you to places. But then what made you to join this course, spending your valuable time? And very interestingly, we have my friend Chakradhar is there. He think he joined from some far off country, taking his time out of his busy schedule, Brunei. And very interesting that being a very senior and high-ranking executive in a petrochemical organization, he did a course spending a few lakhs of rupees with an organization called ILSS. He wants to learn and get equipped to do some social work in the future. So what makes all of you do this? So can I have open section? Can we have open section for a few minutes now? I think we'll start with Chakradhar.
So just before that, there are 3 questions maybe
Yes,
to
yes.
answer.
Yeah.
Shall I read them?
Yeah, please.
First one is, do you mean palliative care includes mental illness also, not just physical illness? Dementia care is palliative. Is dementia care palliative care?
Yeah. Can I have all the 3 questions?
Okay, that is first question. Second one, does palliative care focus only on the person suffering or also provides care to the family members? That is question 2. And question 3, I want to know the role of a volunteer, a non-medical person in palliative care. And I saw unknown patients suffering in IP.
Okay.
In IP, with
Inpatient,
before, I felt very bad.
That's inpatient, right?
That's what that doesn't make sense. I saw unknown patients suffering, maybe in pain, or I felt very bad. We can ask the person that is Raja Ramani.
Raj Ramani, yeah.
Raja Ramani or Roja Ramani?
Roja Ramani it is.
Roja Ramani. So these are the 4 questions. You can answer and then afterwards.
Roja Ramani,
you can also argue.
can you ask that question please once again? A patient suffering in IP, does it indicate patient admitted
That
in
one,
hospital?
we will ask the person themselves to say, Roja Ramani, can you ask the question yourself, please?
Roja Ramani, can you just unmute and ask the question once again?
Yes, sir. Sir, that question is not question, sir. What you ask now, why you chosen this palliative? There is no benefit. For that, I answered, sir. I gave
Okay,
that.
okay, I got it. Thank you for
In
that.
IP, so
Well,
many unknown patients, because of their illness, the family persons also leave the patient in IP, sir.
Roja Ramani, what do you do? Are you a nurse or a doctor?
I am a general surgeon, sir. Bed
Yeah,
sore
general
patients.
surgeon. Okay, sorry. Okay, fine, got it. Where do you
Yeah.
practice, madam?
No, sir. I am a government employee, associate professor at Nellore.
Nellore, I see. Okay,
Yeah.
very nice to know you. Maybe
Thank you.
one of these days you will be faculty for all of us.
Sir.
Okay, yeah, I got it. So I will go to the first question, dementia care. So next to malignancies, next to oncology, if you look at the palliative requirements of patients with various illnesses, next to oncology comes neuro. So people with neurological diseases, particularly neurodegenerative diseases, dementia is a one kind of neurodegenerative disease, like Parkinson's is a neurodegenerative disease. Motor neuron disease is a neurodegenerative disease. So these group of neurodegenerative diseases, they have a very long undulating course with immense suffering to the patient and also the family. So in the earlier definitions that we are talking about serious health related suffering. Wherever there is serious health related suffering, we are palliative care is very, very appropriate and very much needed. Because in most of these conditions, there is no disease focused therapy or there is no cure. So only thing is what we can do is, yes, medicines, pharmacotherapy has a role in reducing the symptoms, maybe slowing down the progress of the disease in certain conditions, improving the symptoms, but still the main focus will be on care and symptom relief. Also, please understand that people with neurological diseases have other problems also. They may be having arthritis, they may be having heart disease, they may be having kidney disease, they may be having pulmonary disease. They also have other ailments. They may be having diabetes, they may be having hypertension, they may be having coronary artery disease. So all these patients that we are talking about, either as a mental illness or a neurodegenerative diseases, they also may have other comorbidities, which may also need palliative approach to the management. So the dementia certainly comes under the umbrella of palliative care. In fact, it is very appropriate that the patients with because the maximum that we can do for those patients is more about care, how to manage their behavioral changes. Palliative care plays a very, very important part in dementia care. So the second question is palliative care, whether it is restricted to the person or the family. So when we look at the definition of WHO, it very clearly says people with illness and their families. See, in palliative care, it is the unit of care is always patient and the family. Many instances, actually it is the caregiver. The caregiver can be a family caregiver, a spouse, child, brother, sister, parent, the caregiver, formal or informal, many times they actually go through more suffering than the patient himself. And again, the suffering of the caregiver can be physical, mental, psychological, social, and all put together. So we always make it a point in palliative care when we go for home care, we always make a point to see that who is the caregiver, we document it, and actually we see how their blood pressure is, whether they are taking their medications or not, and all that. Otherwise, there is something called caregiver burnout. And there are words like compassion fatigue. Over a period of time, they'll be so stressed out that it actually affects their physical health and also mental health. Thereby, as a consequence, the care for the patient also suffers. So it's even looking at the patient's point of view also, it falls upon us, it falls upon the palliative care team, whether it is doctors or nurses or volunteers, to take good care of the family members. It's very, very important. It is not an optional extra. It is part and parcel of what we should do and what we have to do. So I think that answers that question. Then the role of volunteers in palliative care, we'll discuss a little bit about it in the later slides. But as I know, it's a separate class by itself. Sinia, I think the role of palliative care, you have a presentation on that, right? Out of these 5 or 6 modules you are having, one, I think, will be focusing on the role of volunteers and palliative care. And we will be touching on the topic.
Sir, we have one.
Yeah, we'll be touching on it.
We have one.
So how much time we have now?
We have 30 more minutes, sir.
Okay, we'll have to go a little faster now.
Yes.
The earlier traditional model of palliative care was, as long as some kind of treatment was offered to the patient, as long as some kind of treatment was available to the patient, he was undergoing the treatment. Once the treating doctor, the primary care physician, says nothing more can be done, then the patient used to come for palliative care. If at all there is a palliative care, you can look at the top diagram. So it is either or. As long as possible, treat him to cure the disease. At certain point of time, if the patient cannot afford it, or further treatment is not accessible, or the general condition of the patient is such that he cannot stand any more treatment, then the primary care physician says, there is nothing more I can do. You can go to home, or you can go to XYZ, who will provide some pain relief to you. So that was the model traditionally being followed by yesterday's medical teams. So today we are talking about a concurrent model of palliative care. So because of the time, we will go a bit faster. This is a very, very interesting slide. This can give you a very good idea of how palliative care is conducted now. So as per the present practice, we wish that it doesn't happen practically, but we wish that palliative care team comes in contact with the patient right at the time of diagnosis. So why do you need a palliative care team at the right of the beginning of the treatment? Because at that point of time, there is actually ample chance for cure for the patient. At the time of diagnosis, there is ample scope for curing the disease. Then where is the role for palliative care? For lack of time, we'll go to the next slide. I will briefly explain this. It is, the reason is, particularly in third world countries like India, most of the cases are diagnosed at late stage. Very, very few cases are picked up in the early stages of disease, at least in the Indian context. That is one reason why we need palliative care right at the beginning. But even otherwise, even if it is diagnosed early, I want to make an important point. Palliative care is to reduce the symptoms and reduce the suffering caused by the disease and also caused by the treatment. I'll say it again. The consequences of treatment can be very harsh on the patient sometimes. Whether it is chemotherapy or surgery or radiotherapy, they have their side effects. Sometimes they can be very distressing. So what happens is, unable to tolerate these side effects of the treatment, whether, see, if it is chemotherapy, it can be severe nausea, vomitings, diarrhea, weakness, right? Surgery, again, confined to the bed. Radiotherapy, like mucositis, again, weakness, falling blood counts, loss of appetite again. So there are a number of symptoms can be caused by these treatments, which are transient. They will get better over time. But if the patient is unable to tolerate these medications or these procedures, there are people who opt out of the treatment, unable to tolerate the treatments. So if by supporting the patient, you reduce the nausea, you give them by counseling, addressing his social and psychological and other problems. If you can add that additional support, one more additional layer of support to the patient, it may just happen that the patient may be able to complete that course as per the protocol, which gives him a much better chance for cure of the disease. So don't be under the impression that palliative care is only for people for whom cure is not possible. Ideally, palliative care should go hand in hand with disease-focused therapy. If the patient gets cured of the disease because of the chemotherapy or any other procedure, wonderful. Then he may not need any palliative care in the future. But in some cases where the disease progresses, where the disease doesn't respond to treatment or it relapses, then the palliative care's role will go up. You can see as the disease progresses, the role of curative care slowly comes down and the role of palliative care slowly goes up. It may not happen in all cases. That's what I'm saying. Where the patient is cured, they will take a different trajectory. They don't need further curative care and they don't need further palliative care also. Maybe they will come for review after 3 years, after 5 years, whatever the protocol says. So it doesn't mean that each and every case of palliative care, once it starts, it should end with the end of life care. It's not necessary. And the most important part is palliative care doesn't end with the death of the patient. This is again a very important take-home point everyone should notice. Palliative care at least continues for 6 months after their death. You keep contact with the patient's family because there is something called grief, which is a normal process of coping and adjustment. Generally, the family will be, the loss will be there. If somebody says time heals the wounds, it's not entirely true. The wounds remain, but people learn to live with wounds. They learn to live with loss. Generally, they get better. They will be able to cope up with their day-to-day living after about 6 months of time. So you need to support them for the first 6 months by making a periodic visits. After 6 months, generally it will not be necessary. Those who do not get better after 6 months, it is called complicated grief. Something is not right. They need further help, counseling, or maybe pharmacotherapy through a psychiatrist. It may be some of these people need it. So let's come to the suffering. If anybody believes that it is the poor people only who suffer because of lack of these services, it's not true. Poor people suffer because of the ravages of the disease. The suffering is really unimaginable unless you go to the homes of the patients, spend some time with them. People who do not sleep for days and weeks, people who cannot lie down. See this, head down, must be a lot of suffering, alone. But having said that, people who can afford expensive healthcare are no better off. They may be in ICU, in air-conditioned comfort, but they, apart from suffering the consequences of the disease, they have to endure various interventions that are inflicted upon them by the healthcare providers, even when they are fertile. So I want to make a very important point here. There is not, I'm not saying anything against the modern medical care, which performs miracles in saving lives. And ICU is particularly a facility which can make a difference between life and death. ICU is a place where you have all the resources, human and equipment, which can reverse a reversible condition without wasting any time. A minute-to-minute care, minute-to-minute intervention, which can actually make a difference between life and death. We're not talking about that. So what we are saying is, in a segment, a small section of people where the disease, underlying disease is so advanced, it leaves no chance for recovery. We're only talking about that subset of people. That is where these interventions are not called for, and they actually add to the suffering. I think I made my point very clear. Only in those cases where the outcome is certain, and all these interventions that we are trying to do, not necessarily because of the initiative of the hospital. Many times it is because the families insist that something should be done. Telugulo cheptaru, edana cheyali, you have to do something. No, families tell the doctors do something. Families tell the doctors do everything. When the doctor says there is only very slim chance of getting his recovery, that is a message we should understand. But we will tell, even if there is 1% chance, sir, please try. What do you expect the doctor to do? Right? So the problem is with everyone. The problem is definitely there with the medical fraternity. Not particularly, I don't think it's mostly because of the motive to earn money, mostly because they are not properly trained or properly sensitized. That's the main reason. Maybe there may be very few instances of doing it for money, but most of the cases, they, like you and me, they're also not trained. They're not trained properly sensitized for palliative care outlook. Dr. Sankha Mitra is a very well-known oncologist from UK. This is what he says. At the moment, no one gets the good quality of palliative care in most part of India. He runs a non-governmental organization, Palliative Care, in Calcutta and surroundings. The poor die in neglect because there is no one to look after them at the time of death. The middle class die in ignorance because they're unaware of the benefits of palliative care. They could actually pay for palliative care services if they were available. But at the moment, in a market healthcare system, there is no one selling palliative care as there is no one buying palliative care. They are neither available, nor people are willing to pay. Come to the rich. The rich die in agony on a ventilator because there is no understanding of terminal care and prognosis. They are not appropriate for resuscitation. They end up on a ventilator with no benefit to them, with considerable distress. And in a country, low resource country like India, millions of people slide down from above poverty line to below poverty line because of healthcare expenses out of the pocket. And the irony is that in most of the cases, the treatment is futile. So let's look at World Health Organization definition of palliative care, which, as I said, is about 20 years old. We'll just touch upon the important points. It talks about the quality of life of patients. And as somebody has pointed out, it also says the families are an important part of this palliative care. And it says something about life-threatening illness, which many doctors now disagree, because it is not only for people with life-threatening illness. Now we are talking about any illness where there is health-related suffering. So to go through the definition, it also, apart from treating the symptoms, it also aims at prevention of suffering by means of early identification and impeccable assessment. So it's a holistic address of pain and other symptoms. They're all physical. It includes psychological and spiritual support. That is the World Health Organization definition. Next slide, please. Yeah. Palliative care stands on 3 legs. The first being symptom management. The second one is communications. And the third one is psychosocial support. Without an iota of doubt, the first and foremost obligation is to mitigate the symptoms. Without managing the symptoms, nothing else can be done. You cannot counsel a patient who has got severe pain. You cannot support a patient psychosocially or spiritually who is unable to get his breath. So symptom management is #1 priority, any day, anytime. So aggressively managing the symptoms of the patients with critical life-limiting illness or terminal disease can improve the quality of life of patients. Please remember, as long as the symptoms are there, the patient's mind is only filled with the relief from the symptom. It can be pain. Don't be under the impression that pain is the most distressing symptom. Pain is very distressing, but there are equally more distressing symptoms. For example, breathlessness, shortness of breath. Patient will be scared for his life. It is as if somebody is strangulating him. You have to treat them then and there. You don't have time. It's not that somebody is with severe pain and you can take 24 hours to treat the pain. You have to treat severe pain then and there within minutes to half an hour, 1 hour. So it's very important. Unless you treat those symptoms then and there, you are failing your duty. The second thing is communications. Palliative care is all about communications. This is where everybody comes in. Doctors, nurses, volunteers, social workers, paramedics, caregivers. Communications there to be learned. None of us, except few exceptions, none of us know how to talk a person with serious illness. There are things to be learned. We'll be extremely careful before allowing volunteers to communicate with the patients. Many of the volunteers, or even doctors or nurses for that matter, think that it is patients are waiting for their advice. It's not necessarily so. Patients are actually waiting for somebody to hear their side of the story. So before we talk about communications, we need to develop our listening skills. It needs study, it needs practice to be able to communicate well. It's not easy for even the most experienced doctors to communicate with the patient about his impending death or even a bad diagnosis. Even today, I know I spoke to a superintendent of a very big hospital, a general surgeon who is with 20, 30 years experience. He tells me, said, even today, I'm not comfortable with breaking the diagnosis to the patient. I will always ask the patient to go out, ask the patient's son or daughter to come in, and I will discuss the diagnosis and prognosis with him. Nothing wrong with him. He's not been trained. So last and finally, but no less important, is the psychosocial support. So it's what is very important to understand, that all these 4, the physical symptoms like pain, breathlessness, nausea, vomiting, diarrhea, constipation, and whatnot, fatigue. Social and financial, loss of social role, financial problems, particularly in the Indian context, breakdown of family, disruption of family relations, spiritual Why me? Why did I get the disease out of all the people? I done so much good for my family, for my neighbors, for my employees. But I've been a religious practitioner of my faith. Why did God give this to me? This is a spiritual pain. But they all feed into each other. They're all interdependent. Each one of them causes some pain in the other domains also. Dr. Rajgopal always shows these slide in this presentation. One of his patients, he did not sleep for a couple of, maybe some, I think he says about a couple of weeks. His position, he was in that position, he has extensive bone metastasis. He has been maintaining that position without sleep and without food for a couple of weeks. And he was brought to the palliative care OPD. He got about 15 milligrams of morphine, gradually up-titrated within about 15 minutes. And he had his first cup of tea after 3 weeks. This is what symptom relief can achieve. It's not about how long he will live after this. Till such time you do this, he has no life. He's only existing, it's not life, right? He can't eat, he cannot sleep, he cannot sit, he cannot hold his head high. He cannot even think what else is important in his life as long as he's suffering this inhuman suffering. So the biggest responsibility is relief of symptom. It need not be pain. Pain is given as an example, but other symptoms can be equally distressing. Ira Bayok is a doctor, physician. He wrote a very good book, Dying Well. I recommend that you get an opportunity, read that book, or many of his lectures are available in YouTube. So what are the basic elements of human care? Shelter for the elements. Somebody was asking me what is the role of volunteers. I will not go deep into that. There is a separate topic for that. But I'll read this for you. What he has written. Shelter from the elements. A caring society, metaphorically says to the frail or dying person, will keep you warm and dry and will help him with personal hygiene. The community around him reassures the person who is too frail to care for himself or herself, will keep you clean, will assist you with elimination. And family on behalf of society, the clinicians, it can be the nurse, it can be the doctor, it can be the nursing aide, says, will help you with your bowels and bladder function. We'll provide you food and drink. We can always say we will offer you something to eat and drink and help you to do it, help you to take that food. And very importantly, keeping company. Society can say to the people who are dying, especially those who are unfriended, who are, what you say, left unattended. You will not have to go through this time in your life entirely alone. We'll be there with you. And these days, with so much of knowledge, with so much of technology, with so many drugs, now we can say, we can always say, we will do whatever we can with as much skill and expertise as available to lessen your discomfort. Earlier, we were not able to say this, but now we can say that with all the training, with all the tools that we have in our hand, now we can say we can alleviate your pain. We can reduce your breathlessness. We will see that you're comfortable. We'll see to the last moment, as long as possible, that you do not suffer. This is a very important commitment that we can make, and it makes a very difference very big difference to the patients. Everybody is afraid of death, but just go deep into that. Why they are afraid of death? You know that why people are more afraid of death? They know that many of these patients know that they are going to die. But what does the fear bring about? The fear is about abandonment. I will say it again. The fear is at abandonment. The fear is that they will not be attended. When they are going there alone, there will be nobody by their side. And they might have seen one of his relatives, brothers or parents, dying with pain. Now he equates that. Now he says, when I die with pain, or I die with breathlessness. These things we can ensure them that it's not to be. We can give them commitment that they will not be abandoned. We'll be there with you. It is up to everybody. The family, son can say that, wife can say that, husband can say that, nurse can say that, doctor can say that, volunteer can say that. We'll be there with you. That's very important. That's what he's looking at when he is afraid of death. Actually, he is afraid of, yes, he's afraid of death, but more into it. He's also more afraid about abandonment. He may accept death, but he cannot accept that he'll be left alone. He cannot accept that he'll be left to soak in his urine, in motion, in his pus. Nobody can accept or get prepared for that. And nobody can ever get prepared for, I will suffer with pain and breathlessness and whatnot at my time, when my time comes. Right? So these are assurances that are very important for the family and caregivers to give. Another 5 minutes. A very brief glimpse about spiritual suffering. I don't think anybody, did anybody answer to my question? What brings you, just one or two people, what brings you here? It is, why are you bothered? You're healthy. You're busy with your profession. Maybe you're donating something for the charity. You're doing good for your friends. Maybe you're somebody who is in need. What brings you here? Why do you do?
I wanted to.
Yeah.
I wanted to start a senior care home. Yeah, so it came in earlier this year, and it engulfed me. I couldn't focus much on my work, so I thought I will try it out. If I don't try this out, I might feel very sad later in my life.
Thank you, sir, for sharing that. Anybody else?
Sir, I lost my husband to esophageal cancer. He was under palliative care. And having gone through that myself, I can understand and relate with the pain and the suffering, or rather the emotional turmoil that we go through, basically the patient and the caregiver. So since then, I have been associated with various NGOs. I go there as a volunteer and assist them, spread awareness of cancer, recommend regular screenings, assist patients during their hospital visits, and so on and so forth.
Thank you. Madam, may I know your name?
My name is Reena.
Reena, thank you very much. It's not easy to share these things online. I really appreciate you for this. And I am sure each one of us in this group share a little pain with you. Thank you very much for sharing it. It actually makes a difference.
Thank you.
Hello.
Yes, sir.
This is Dr. Srinivas Rao from Tirupati.
Yes, sir.
I did my palliative care course in 2008. Since 2008, I am doing in palliative care physician in Tirupati. So we want to establish a palliative care clinic in our government hospital. That's why we received a message from you, so that you are giving a training for the volunteers. So that we can also train from some volunteers and to establish the palliative care here.
I see.
And moreover, I can also some brush up because I have undergone training from long back.
Great, sir. Thank you.
So that I can brush up my knowledge once again.
Yeah.
Along my volunteers, so that I can do whichever is possible for me.
Great, sir. I remember having come there. I think I came with Gilly Brown. Some maybe 2-3 years back. We came there for to.
You came to SWIMS, I think, sir.
Yeah. That's right.
SWIMS is Sri Venkateswara Institute of Medical Sciences, sir. Ours is Sri Venkateswara Medical College, Tirupati.
I see, I see. Okay,
GGH.
I understand. Yeah.
Dr.
Okay, sir.
Bharati, I think.
Okay. Yeah, right.
She guided.
Yes.
She retired recently as a
She was
organic.
she conducted that event on that day. Yeah, I remember that.
Yes. The Bharati wants to establish palliative care.
Okay.
So I'm already on the path.
Okay,
So that
excellent.
how much help I can do, because I'm an anesthesiologist.
Yeah. You're the best person to do it, sir. With anesthesia background, you'll be able to do much more than any one of us.
Yes, sir.
Thank you.
That's why I want to brush up my knowledge along with
Thank you. Thank you, sir. Thank you.
Thank you, sir.
So what connects you in the world? For many, it is God and religion, but not necessarily for everybody. For a lot of people, it is more about relationship. For some people, it is grandchildren. For some people, it is home. And it is surprising that for some people, it can be pets. It can be a tree outside that window. No, spirituality is not confined to organized religion or God. So this is again something very important, meaning of life and purpose of life. So many of these people with serious sickness, they feel that life is useless. Life is without purpose. They start feeling that I'm a burden now. I have nothing to contribute to this world, not to my family. My whole family is suffering because of me. They're suffering financially. They had to give up their careers, or they have to give their time and everything for me. No, this is a very depressing thought, and people will be going through this. This is actually, this is where our volunteers, our counselors, they have a very important role to play. There is a value that can be achieved at any point of life, even at the time of death. We don't have enough of time to discuss these things. But again, I strongly advise you to go through some of these lectures. The book is Dying Well. There are many lectures given by him. How you can create value even in those last few weeks and months. It's very
Excuse me,
enlightening.
sir. Somebody has asked for the author of that Dying Well book.
I'll just show you that book title, right? You can note it.
Thank you.
Okay. So ultimately, giving a purpose is very, very important, if possible. Sometimes it may not be possible within the time left, but if nothing is possible, give them love. Here, there is no exception. Make them feel wanted, make them feel important. There is no exception to this. If nothing else works, prescribe love. So there is a medical establishment, a big hospital, hospice, and all that. And here we have an isolated patient. There is a large gap. And this is where you exactly come in. This is where you come in. The meso element of social capital. You know social capital? Social capital is the product of human interaction with shared values. You are the bridge between this establishment and this isolated patient. There are certain core values. We'll just go through them very fast. Always, this is again from Palliative. Rajgopal says very favorite subject. Always keep the patient first, no exception. Family second, and organization secondary to first and second. Care is the right of the patient and his family, and we stand committed to provide it to them. It's not a charity that we give it to them. And the patient and his family are actually giving us the opportunity to care for them, and they are helping us, enriching our lives. Compassionate and competent care, valuing human dignity is at the heart of what we do and why we exist. A very important point is we shall try to do the right thing for the right reason as best as we can. This is much more than what it appears to be. We're talking about competency. Just compassion is not enough. Crying, sitting with the patient doesn't give him any consolation, right? You need the tools, you need the knowledge, you need the skills to make a difference. This is very important. Just because I'm a volunteer too. But that doesn't give me any right to give substandard care to the patient whom I'm attending, because I'm doing it without taking anything. That applies to you and me. Okay, I may be a volunteer doctor, you may be a volunteer nurse, somebody may be a volunteer social worker, doesn't make any difference. Just because we are not taking a fees gives us no right to provide substandard care. I will repeat it once again. So somebody said about competency versus compassion, right? If you had to choose between them, what do you choose? Somebody said, I will choose competency over compassion, but I will not go for that. I will go for some other comment made by somebody else. We and our patients assume competency. It's not a if. We assume competency. Whether it's a doctor or nurse or a volunteer, it is important that they should be competent and they should strive for that competence. We all should strive for that competence and consider it as our minimum standard, not an optional extra. And competency means nothing without compassion. Competency is foregone. When we go to the patient, better make sure that you're competent, irrespective of your role. So it is not a if and but competency without compassion is nothing.
Sorry to interrupt, sir. We are nearly past the time.
I'm closing. Let me close it now.
No. So if you conclude in whatever way in the next few minutes, because we have gone past.
I'll do that, madam. Sorry for that. Sorry for shooting you. I mean, going beyond your time. We'll close it now. We're coming to the end, right? So we recognize the strength of the social capital. It's very important for each of us to understand that each one of us we come across, whether they are a staff or patients or anybody, they're superior to us in some way or the other. This actually improves our relations with our patients, with our families and our colleagues. The whole medical practice is based on 4 most important medical ethics. Autonomy in simple terms is patient has got every right over his body. He has got right to accept or refuse the advice or treatment that you give. Beneficence is, it is the responsibility of the doctor and the medical healthcare provider to always think about what is good for the patient. And non-maleficence is do no harm. Justice is equitable distribution of resources, whatever resources you have, irrespective of the social or economic status of the patient. These are the fundamental pillars of medical ethics, which should guide us our transactions in day-to-day life. So this is, you can write, note down, The Dying Well is a book written by Dr. Ira Bayok, a wonderful book. Even if you don't read the book, there are many lectures given by him. They provide very nice insights about care for the terminally ill people. This is the vision of Palliative India, an India in which palliative care is integrated in all healthcare settings, so that every person has access to effective pain relief and also quality palliative care, along with disease-specific treatment. Again, please remind that it is not either or. It always goes along with wherever it's possible. These are the key points which you have seen earlier, just for remembering the 5 key messages that you have to carry. A very important point to remember: how people die remain in the memory of those who live on. So when you're caring for the patient, those memories are carried by the family members for their lifetime. So do a very, very good job about it. Do something powerful, one life at a time. Thank you very much. And I'm sorry that I took a little more time than what has been given to me. And if I'm willing to take any questions, if time allows.
Yes, yes. Sinia, can we come out of the presentation, sir? Sir, thank you very much, because see, like you've explained it so well, especially like what is core palliative care. In nutshell, as I would say, it starts from the beginning. That is what has to be understood. So you have defined it so well. And another important thing what I would like all of you to take is how he mentioned about intensive care. Not that if some patient will get benefit, we will do 200%. I normally say, so something correctable, we'll do 200%, not even 100%. But if the same situation inevitable, even you do everything, success or positive outcome will not happen. There, if you spend, you are drawing the resource of the family unnecessarily, which can be used for the surviving family. So that is what was explained so well. I would say crisp, correct, so well by you, sir. And that is some take home. And I have seen all the messages which have been in the chat box, like regarding so many organizations from that Dr. Net and then NGOs. We are going to be, God willing, I'll be with you all these 5 days, and I'll keep on communicating with you what much we can do to help. Volunteers do play a big role, and all 5 days we'll be telling you where, how volunteers can be helpful. And it's team working. Palliative care is team working. There's no I in team. So all together is what we are going to do. So big thank you for Dr. Raju for taking us through.
Thank you, madam. Thank you, everybody.
So, and all of you, like, keep your questions, even like whatever we have answered today, even what you have, keep rest. What else we can, we'll answer. Even if something could not be answered by me, we will get in touch with Dr. Raju and get the reply for you also. Like as much as possible. I have also been with Palliative for a few years, so we will all try to justify as much as we can. And a big thank you once again. And once again, the author request was that which you've already shown. And then slides will be shared. Sinia, am I right or not? We can share the slides.
Slides are
Yes, we will share slides of all presentations. Okay. So
I'll be more than happy to provide any more resources out of which, I mean, whatever
exactly.
we have. Yes.
That's what we will. We can, Aravindan, I think he's from the Dr. Net. So we will keep, because as many states don't have what Kerala has. But if we all try, we can. That is Dr. Rajagopal's wish. Let us all wholeheartedly work towards it so that palliative care reaches to whom needs it. As Reena has mentioned, all of you, either in your family, not necessarily a cancer patient, could be an elderly, dementia, dying. So everyone will have someone in your where you could participate. That's why there's a statement. Either you'll be a carer now, or you may be one who needs care later on. So this is only a transformation in our life. Okay. So thank you once again, and we will continue our journey in this whole week to finish as much as.
Sinia, you can share my telephone number or email if anybody is interested.
Yes, we will, sir. We will, sir, and we will share the presentations, and I will hand it over to you, Sinia, and big thank you to Dr. Raj.
Thank you so much, Dr. Raju, for that elaborated, wonderful session.
Thank you.
Thank you, Sinia, and thank you one and all. We'll all see. Like Sinia, you will.
Yes,
you will go ahead with the rest of the communication. What you want to convey to them. I'll hand over it to you.
Thank you so much, ma'am. All the other details, the session recordings and the PowerPoint will be shared in the WhatsApp group. Thank you all.